Hey folks, in this second video of chapter 18, we're going to be talking about depression, and then we'll talk about bipolar disorder after that. So, what is depression? It's the symptoms of depression, I think, are pretty familiar to most people because most people have either had depression or know somebody who's been diagnosed with depression. In general, one of the primary symptoms is anhedonia, which is a lack of capacity to experience pleasure. This is combined with negative thoughts, despair, hypoactivity or lack of activity, sleep disturbances, withdrawal, lack of appetite, self care, and then suicidal thoughts. You don't have to have all of these symptoms to be diagnosed with depression. Essentially, what you need to have is a depressive episode with a number of these types of symptoms that last at least 2 weeks long. Okay, so being sad for a day or two, or not really being able to sleep well, or not feeling like your normal self for a day or two, isn't a major depressive episode, and you wouldn't be diagnosed with major depressive disorder. You might still want to get therapy or talk to somebody about it. That's great, but you wouldn't necessarily be diagnosed with a disorder unless that episode lasts for 2 weeks or longer, which would really suggest a situation in which that's going to be causing issues for your life. You can differentiate depression into reactive and endogenous depression. It used to be the case that we would kind of write off reactive depression and suggest that this is just normal behavior. But reactive depression is in response to a negative experience. So maybe you get divorced, or somebody in your family dies, or something negative happens to you. If your depressive symptoms last for 2 weeks or longer, um, then certainly your life is being affected negatively by that reaction, even though it's reasonable to be sad about it. If you're still being influenced by that 2 weeks longer, and especially if you're feeling suicidal thoughts, or sleep disturbances, or lack of self care, it would be time to be diagnosing a disorder at that point anyway. If there's no apparent cause, no specific negative experience tied to it, then this is endogenous major depressive disorder. About 1 in 10 people will suffer from unipolar depression, which is just major depressive disorder, in their lifetime. This is twice as likely to be diagnosed in women than in men. Depression is a problem, of course, because 4 to 15%, we're not quite sure, it's a range, of people suffering from major depressive disorder will complete suicide. This isn't just attempting suicide, this is completing suicide. There are a couple videos in the slides here that I encourage you to watch. In this video, we see a gentleman who was undiagnosed with depression for a long period of his life. He describes that about the symptoms that he had, that he thought he had for probably quite a while before he ended up being diagnosed with depression. And talks specifically about a lot of feelings of worthlessness, negative thoughts about himself that's characteristic of depression. And in this video, we have a case of somebody describing self harm and describing some dissociation during the self harm period, which is also um, somewhat common in major depressive episodes. So each of these presents sort of different clusters of symptoms associated with depression. But are representative of the kinds of negative thoughts and behaviors that you can see. In terms of risk factors, just like with schizophrenia, we've got some genetic components and environmental components. So we have about 30 to 40% concordance in monozygotic twins. So if you have major depressive disorder, your monozygotic twin has about a 30 to 40% chance of also getting major depressive disorder. Certainly not 100%, right? Which suggests that there's more than just genetics going on, but certainly a genetic component. They've implicated 2 loci on chromosome 10 that seem to be implicated, so you may be able to predict a little bit some predisposition, again, for depressive. And again, researchers think that with major depressive disorder, the genetics might lead to a predisposition toward depression. And that predisposition may then be activated by environmental factors. What environmental factors are involved here? Well, stress is certainly one of them. Major depressive episodes are more common to occur in response to stress, being activated by stress. Some other environmental factors that certainly point to major depressive disorder not just being genetic are seasonal affective disorder and then peri or postpartum depression. So in seasonal affective disorder, you get depressive episodes during the winter months, which seems to be caused by the lack of light. So in the northern hemisphere, for example, the winter months have much less light than the summer months do, and that environmental difference of not having access to light exposure seems to lead to depressive symptoms. And in fact, a light exposure treats seasonal affective disorder. If I get a light box and I stare at the light box, it helps out. Postpartum depression is quite common. 1 in 10 mothers will experience peri or postpartum depression. Peripartum depression is depression during pregnancy, and postpartum is after pregnancy. And so about 10% of mothers will experience this, which can be quite disturbing at times, because sometimes mothers will feel very down and have a lot of negative thoughts, and will sometimes even have thoughts about harming themselves or harming their babies during these depressive episodes. And this is likely due to steep hormonal changes, right? So due to pregnancy, there's large changes in hormone levels, and that major fluctuation in hormone levels may trigger a depressive episode, particularly when somebody is predisposed to depression already. So people who've had previous depressive episodes are more likely to be in that group that gets postpartum depression. Okay, so we know what depression is. We know some of the risk factors of it. Let's talk about how to treat it. And I'm going to have a table here that's got a lot of information, mostly for your reference. But the thing to kind of pull out from all of this kind of combined is that antidepressant drugs typically agonize monoamines. And agonization means that it increases the activity. Okay. Monoamines are serotonin, norepinephrine, and dopamine. We've heard about these before. So there's a number of different drugs that work on these monoamines in different ways. So the very first antidepressants were MAOIs, which inhibit monoamine oxidase. So if I inhibit monoamine oxidase, I get less breakdown of these monoamines, which means more monoamine activity. You may have heard of Marplan or Nardil. They're kind of older antidepressants. There's some issues with MAOIs because these treatments interact with diet and with other drugs and can cause blood pressure issues, so they tend not to be prescribed very often. Tricyclic antidepressants were kind of the next wave of antidepressants, and these block reuptake of monoamines, and they do so pretty generally. So they block reuptake of serotonin, norepinephrine, and dopamine, and they have other effects too. So they block histamine receptors and do a number of other things. So they're pretty general drugs. And so if I block reuptake of these monoamines, remember you get the neurotransmitters go into the synaptic space and they get taken back up. That's reuptake. If I block that, then I get more monoamines here, means more activity. So tricyclic antidepressants were kind of the next wave, and they have these kind of general effects. And so after that, people started to develop more specific ones. So if I want to not block all of these monoamines, block reuptake of all of these monoamines, maybe I selectively block reuptake of an amine. So I can block norepinephrine only, NRIs. I can block reuptake of serotonin only, or I can block reuptake of just norepinephrine and serotonin. And here's some examples of drugs that you might have heard of. These are the most popular treatments But of course, it turns out not necessarily more effective than MAOIs, tricyclics, or any of the atypicals. So they're most popular, potentially due to marketing, and potentially because just a general bias to maybe try to mess with one neurotransmitter more than you want to mess with multiple neurotransmitters. There's a number of atypical antidepressants that also work, that have various effects on dopamine. Some of them affect acetylcholine, some affect melatonin. Wellbutrin is considered an atypical because it doesn't affect serotonin at all. It just affects norepinephrine and dopamine. But anything that doesn't do these effects is considered atypical. Here's a figure just displaying the general idea of how these antidepressants work. Okay, and remember, the general idea here is to agonize the monoamines. So I want more activity. And I can do that in two ways. I can block MAO, okay, which prevents it from breaking down the transmitters. So if I block the breakdown of transmitters, I get more of those transmitters. Cool, so I agonized it. So that's why MAOIs work. In terms of the tricyclics and the SSRIs, what they do is they block reuptake. And if these neurotransmitters are in the synapse and they can't be brought back up, they can't get recycled back up, then I'm going to get more activity of serotonin, norepinephrine, maybe dopamine. Okay, so do these things work? And the answer is yeah, and then followed by more or less. So they do kind of work. So they actually get prescribed because in clinical tests they have shown to reduce symptoms of depression. But it turns out they don't work for everybody. About 50% of patients improve with drug treatments. And it turns out that placebo effects are fairly high. So in this figure over here, we have improvement, and a 0 would indicate no improvement. And we've got the placebo conditions here in the circles, and we've got the drug conditions here with the triangles. And a placebo is like a sugar pill. There's no drug in there at all. And it turns out that everybody's above 0. So about, on average, about 25% of patients improve just by taking a placebo. And then 50% improve on the drugs, on the SSRIs or the tricyclics. And it doesn't particularly matter which one you take. Okay, so you're getting about 25% from placebo and about 25% from the drug, all told 50% in total. Another interesting phenomenon is that the drug treatments seem to be effective in severe cases of depression when your symptoms are very high, and less effective for low severity depression. And this may, again, be part of this kind of placebo effect, right? So if my symptoms are very high, they're maybe the highest they could possibly be, it may be easier for me to pull back down to normal. Maybe I'm at the extremes here. Okay, so we've got these kind of caveats to, yeah, the drugs work. Some of that seems to be a placebo effect, which is fine as long as it's working, right? Some of it's a placebo effect, and then some of it is conditional or interacts with the severity. So it's going to be more effective if you have severe depression than mild to moderate to low depression. Okay, so there's the drug treatments. What about brain differences? So it turns out there's some general reductions in brain matter in participants or in patients who have depression. So there's reductions in gray matter, which are the cell bodies, the somas, in a few different areas in the prefrontal cortex, especially the medial prefrontal cortex, where we process emotions, remember? And the amygdala, where we experience things like fear. And then the hippocampus, where we process new memories, and then the cingulate cortex. There's also reductions in white matter, or the myelinated axons in the frontal lobe as well. Okay, so you get some differences. You get some maybe developmental differences in brain structure in people with depression. We got a few different theories for why depression happens, and these are biological theories, right? So these aren't like psychoanalytic theories, for example. And the first theory is that it has to do with underactivity of monoamines, right? And this is based primarily on the fact that um, agonist drugs work. So SSRIs seem to work a little bit. Tricyclics seem to work a little bit. And because those work, it means that maybe the monoamine levels are responsible for depression. Note that your diet can also change your monoamines. So if you eat tryptophan and eggs, poultry, seaweed, and soy, that increases serotonin levels a little bit. Um, so the theory would be that these drugs or your diet might be able to change your monoamine levels. But remember, the effectiveness of these treatments isn't all that great, and other drugs work too. So things that influence acetylcholine also seem to work, and histamines also seem to work a little bit. So another theory exists for depression, and that's the neuroplasticity theory, which suggests that the symptoms of depression are due to altered neuroplasticity in the brains of people with depression. So this is reductions in neurogenesis in the hippocampus. Remember, the hippocampus is a little smaller in people with depression. Um, and reduced neurotrophin synthesis. Remember that neurotrophins are responsible for creating new synapses and dendritic branching in neuroplastic changes in the brain. So it may be that differences in these kind of neuroplastic changes in the brain might be responsible for some of these symptoms. And the general idea on why these treatments work is that they can facilitate neuroplastic changes. So if I ramp up levels of monoamines, serotonin, norepinephrine, dopamine, right? If I ramp up levels of those neurotransmitters, that may set me up to increase activity in different parts of the brain, which may then increase the amount of neuroplasticity that I'm engaging in through that activity. And this is kind of consistent with the fact that the treatments take about 2 weeks to work, right? So ramping up monoamine levels don't immediately reduce symptoms of depression. They may have longer term changes. So ramping up monoamine levels may set me up for longer term neuroplastic changes. And so there's a category of treatments that aren't drug related that play with brain stimulation um, that may be due to this neuroplasticity um, idea. One of those techniques is transcranial magnetic stimulation, where you take that magnet that we've seen earlier in the semester and you stimulate with a magnet across the brain, right, in order to activate the prefrontal cortex with magnetic pulses. So, activating your prefrontal cortex with the TMS seems to reduce depression symptoms. Deep brain stimulation, you actually implant electrodes just under the scalp here that's stimulated by a controller here. And these electrodes go deep into the brain to the anterior cingulate. I'll show you a picture of that in a second, and stimulate that part of your brain that's not on the outside. And then the third option is maybe the most extreme, called electroconvulsive therapy, where you get electrodes, sometimes unilaterally, sometimes bilaterally, that induce a seizure in patients who are unresponsive to other treatments, and essentially stimulate activity of the brain. Almost kind of like resetting activity of the brain through the seizure activity. All three of these techniques have been shown to work to reduce depression symptoms. And one of the reasons they may work is that they stimulate these neuroplastic changes. They stimulate your hippocampus, your frontal lobes to engage in changes in neuroplasticity. And it turns out that these and the drugs are all best when they're paired with talk therapy. So we may be biologically setting you up for neuroplastic changes, and then the talk therapy can direct those changes, perhaps in more adaptive ways. Here's that anterior cingulate gyrus that seems to be the target of deep brain stimulation. So stimulating this area of the brain with those deep brain stimulators seems to reduce depression symptoms. Let's talk bipolar disorder here at the end. We don't have a ton of content on it, but bipolar disorder is distinguished from depression only somewhat. So bipolar disorder includes depressive episodes, major depressive episodes, and then includes at least one period of a manic state. So it has at least one depressive episode of 2 weeks or longer, and then at least one manic state over the course of one's life, essentially. There are two kinds of this. Bipolar 2 has hypomania, where you have reduced needs of sleep, high energy, and positive affect. This isn't just like normal, like I'm living a normal life. This is like higher than normal levels. This is oftentimes reported as being pleasant and productive, at least for the time being. Bipolar 1 involves mania, so not hypomania, like regular mania. And in this case, the manic episodes are extreme, and they usually include delusions of grandeur, overconfidence, impulsivity, and distractibility. People can be particularly dangerous to themselves or others during a manic period. Now, in media, bipolar disorder is oftentimes represented as occurring over the course of maybe minutes or hours. So somebody's mood is shifting very quickly from a manic to a depressive state. I mean, it turns out that's not how bipolar disorder works. Cycling occurs over the course of months or sometimes even years. Okay, and rapid cycling bipolar disorder is if you have more than 4 times per year. Okay, so 4 times a year is every 3 months, moving from a depressive state to a manic state. And so you can see that these are not daily or hourly changes. There's a video here with a case of bipolar disorder. She describes some hypomanic and some manic situations, some depressive situations, and how that affected her life personally. We have risk factors. Here, the genetic concordance for bipolar disorders is the highest of anything we've talked about so far, 80 to 90% heritable according to estimates. So if you have a twin with bipolar disorder, you're very likely to also have bipolar disorder. And because of this, it's been a little bit easier to find specific genes responsible for bipolar disorder, some that code for calcium channels, which control the release of neurotransmitters, if you remember, and then some that are responsible for the nodes of RONVA. Those specific genes seem to be involved, or at least predictive of, or predispose one to bipolar disorder. Treatments for bipolar disorder tend to involve mood stabilizers. So sometimes, if you're in a depressive state during bipolar disorder, sometimes they'll give you an antidepressant. But oftentimes, if you're known as somebody who can cycle in bipolar disorder, they'll give a mood stabilizer like lithium. And lithium actually was discovered essentially by the ancient folks in Rome and elsewhere who would recommend bathing or drinking in natural springs. And some of those natural springs that people recommended bathing in, it turns out, are very high in lithium salts. So reports of going to these springs and bathing in them and then feeling very relaxed and having your mood stabilized may be due to the lithium levels in those springs. And then later on in the 20th century, using lithium to treat bipolar disorder was discovered essentially by accident. So somebody injected the urine of manic patients into guinea pigs and then tried to make the urine less toxic using lithium, and then discovered that the lithium had some beneficial effects. And so he's like, let's try this on humans. So we got eventually to this treatment called lithium. It's actually now the most common treatment for bipolar disorder, so at least the most common medical uh, pharmaceutical treatment for bipolar disorders. Anticonvulsants and antipsychotics are also sometimes prescribed for stabilizing the mood. So why does the bipolar disorder happen? Well, it seems like there are a few things going on in bipolar disorder. Number one is that there's neuroendocrine system issues. So the HPA axis, hypothalamus, pituitary, adrenal gland axis dysregulation. So being able to regulate your endocrine system. And then also same thing in the circadian rhythms, those hormones that we use to cycle day-night. In people with bipolar disorder, each of those neuroendocrine systems are a bit dysregulated or disrupted. So that might be partly responsible. Another factor seems to be differences in neurotransmission. So GABA and glutamate, and then also the monoamines all seem to be a bit different levels of activity in people with bipolar disorder than in controls. And then finally, neuroplasticity, similar to the explanation for depression. There are lower neurotrophins in folks with bipolar disorder than in controls. Okay, another thing to point out in your textbook is a really interesting chapter because they describe this case of SB. Who it turns out is somebody that you should know if you're reading the textbook. So you can read that, or you can watch this chalk it up video describing that case. And he's somebody who started with what he thought was depressive symptoms, and then it turned into what he discovered to be bipolar disorder, and then he discovered some treatments for that as well. So that's it for this video. We'll come back and finish up on anxiety and then next time.